Kia ora koutou, no mai haere mai, ko Catherine Hall aho. For those of you who don't know me, my name is Catherine Hall and I am the Chief Executive of Alzheimer's New Zealand, and it's my very great pleasure this afternoon to welcome you to the second in our webinar series, Dementia Rights Are Human Rights. So thank you for taking the time to join us today. The first webinar focused on what are dementia rights and really provide a framework for this webinar and the last one in the series next month. So if you haven't managed to catch that one, you can do so over on our website, alzheimers.org.nz, or you can do so on our YouTube channel. So this webinar really focuses on our experience during COVID and how that's affected people's rights and opportunities. We all know what a big impact COVID had for all of us, and particularly so for those vulnerable people in our communities, and none more so really than people who are living with dementia. And so today we're going to hear about some of those experiences firsthand. So we have 4 speakers for you today, Ted Normanton, Lee-Fay, Heather Lackner and Diane Turner. And I will be introducing them shortly. But first, just a few housekeeping matters really related to this webinar. So we are using a different platform than many of us are used to at the moment. We're all used to Zoom, and this one's on a platform called Demio because we're trialling this. And it does work a bit differently, but your camera and your microphone are turned off for this webinar. But we do want to hear from you, so please do contact us through the chat box, which you will find on the right-hand side of the screen. And if you can't see it, then just click on the chat icon on the top right. So please ask your questions or make any comments on the in the chat box. I'd ask you to do that earlier rather than later, because the earlier you ask your questions, the more sure we can be that we'll be able to pull them all together and put them in front of our speakers. If they're all left to the end of the session, we might miss some, which we don't want to do. We will be leaving the questions though until the end of the session, until we've heard from all 4 of our speakers. In the meantime, if you do want to close your chat box at any time, you can do so again with the horizontal arrow, which is at the top right of your screen. One thing that we have learnt from the last webinar is that if you do have a lot of tabs or a lot of windows open while you are in this webinar, you might find that it's a bit slow to load and there's quite a lot of delay. So if you're not using those tabs or windows, it might be a good idea to shut them down now. Now, one of the things we started in our first webinar is we started the practice of giving our speakers a virtual applause. So we'll be doing that after each of our speakers, and I'll cue in for that. So please do join me in that. And just a quick reminder again to our 4 speakers today, make sure that you keep your microphone and camera off until I introduce you, so that we can just keep the noise and other things to a minimum. All right, so that's got all of the housekeeping out of the way. And so now I'm delighted to introduce our first speaker this afternoon, Ted Normanton. So Ted is living with dementia. He's very active in his local community, and he's very active with Alzheimer's Taranaki. And he's also active in the local arts scene, writing plays, writing songs and writing poems. And indeed, some of you may remember Ted from our 2018 conference where he presented a poem. Well, today we're very privileged to have Ted join us again, and he's going to be presenting a poem today about his experience with COVID and the experience of those close to him. So Ted, I'll just ask you to turn your camera and your microphone on. Wonderful. All right. Can you hear me there?
Yes.
Okay there, Ted? All right. I will. So I'll leave the floor to you, and you have 15 minutes for your poem.
Tēnā koutou katoa. My contribution comes in the form of 2 rhyming poems. One, a personal account of my coping with life during lockdown, and the second, an overall commentary on how people's lives were affected in trying to come to terms with the state of emergency with the lockdown enforcement. Let me begin with the overall account. Breaking news, brace yourselves for this announcement. It will cause much alarm. We are facing a pandemic outbreak which will impact on our state of calm. Named coronavirus, its origin is unknown. Needing urgent tracing, investigations have grown. Backtracking to late last year, a suspected virus attack was creating a scare. Hence, COVID-19's adopted name, too searching to establish blame. Leaked information caused worldwide concern. Of potential dangers we began to learn. No wonder it triggered people's emotions, medical experts filled with notions. A wide network was soon taking hold. Drastic action would soon unfold. A sudden lockdown took effect. Worry uncertainty it would reflect. With symptoms being identified, suspected victims were taken aside. Through intensive testing, a diagnosis was made. Through intensive reading positive, in isolation they stayed. They were cut off from family, friends and places. Disquiet grew with more confirmed cases. Government intervention signalled a serious plan. Many daily aspects were subject to a ban. Certain measures put in place, a lot of people found hard to embrace. 4 alert levels were worked out. The most critical, level 4, here living daily was restricted to indoors. Self-managed group bubbles were purpose-driven, but full cooperation wasn't a given. To aim to keep the public safe, stringent rules were applied. If found out to have transgressed these, under law you could be tried. Social distancing, the majority found hard. Even worse still was crowd gatherings being barred. Except for essential services, all others had to shut down. The absence of workers and shoppers made the CBD resemble a ghost town. Carpooling was encouraged in one's own bubble, but if you drove around needlessly, you landed yourself in trouble. Road checks caught out drivers with their sneaky ways, likely feeble excuses in what they had to say. Panic set in, stocking household supplies. Shelves left empty came as no surprise. Customers waiting in a long queue, a test of patience in anyone's view. A limit on numbers you had to accept. Using security guards, a watchful eye was kept. Hygiene took on a more rigorous routine, and everyone had to come clean. Importance of hand washing kept being reinforced. The use of sanitizers was heavily endorsed. As a safeguard for COVID-19, travellers were put in quarantine. A good number of them bucked the rules, and rightly so, were called fools. They were smartly rounded up to answer for their actions. Outcries of disgust came from many factions. Media coverage took on a far-reaching role. Reports close to the sources as the pandemic took its toll. There were daily TV broadcasts to bring you up to date. Prime Minister Jacinda had a lot on her plate. Her positive approach made for reassurance. The referred to catchphrase, "Unite against COVID-19, hence." As with press conferences, there are questions from the floor. Reporters, in turn, wanting to learn more. Next, the Director General of Health gave his address, keeping the people well informed in dealing with the mess. With case statistics on the rise, containment of loss of lives, COVID-19 defies. The aftermath had harsh consequences. Folk struggling to come to their senses. Job losses increased by the day, causing much stress without regular pay. With small businesses forced to close down, an air of uncertainty hit the town. The government stepped in to support them financially, to compensate for loss of trade and sales, essentially. In the old Kiwi way of life, we have learned admirably to deal with strife. Neighbourhood support we depended on, and that of family, of course. The role of essential services came quickly into force. Supermarket workers had to do long hours. Their efforts were widely recognised in doing what they could do within their powers. There are important lessons to be learnt from our plight, the simplest being a must to do things right. Prime Minister Jacinda was truly inspirational in her addresses to the nation. Outpourings of aroha and reassurance were worthy of her station. New Zealand, Aotearoa, Tutika, stand tall. In the time of hardship, you have answered the call. Heeding advice given with safe measures put in place, and a revival of community spirit, it has been a well-run race. The recovery process will be long. United we stand. Kia kaha, stay strong. Now it's a pleasure to present my own personal account. I couldn't believe what I was hearing. It seemed like a bad dream. How could such a thing happen? But I wasn't about to scream. A lockdown being put in place was a drastic move, but it was the right one, as subsequently would prove. A new virus spreading like wildfire was enemy number one, and so it would be a long time before its course was run. I hadn't cottoned on to it being such a serious matter. A short time passed before I gotten on the natter. Confined to my home, I found hard to accept. Unable to engage normally, of course it was inept. I had to take stock of what was transpiring. That a pandemic was confirmed, there could be no denying. I knew better than not to heed advice given. I had a moral obligation, health safety driven. Physical restrictions I grudgingly faced. Most of these were activity based. Playgrounds were off limits, so the muckle I couldn't take there. Mega Bounce was closed indefinitely. To the kids, this seemed quite unfair. What I missed most were grandkids in the house. But I suppose it gave me more time with my spouse. FaceTime on an iPhone came a distant second. Fond words and kiss blowing were all that I reckoned. I didn't get to act the goat to make them laugh and smile, throwing and hitting a ball to show off my flashy style. Regular routines went out the door. Can you move yourself? My wife would implore. Normally, I had trouble enough. Giving me the hurry on got me in a huff. Battling with my state of mind, I lacked motivation. What I was missing out on felt like deprivation. Boredom was a hard thing to fight, hardly an excuse for sneaking a bite. I admit to having more time in hand, and things didn't always go as planned. Housework became less of a chore, and grocery shopping, some people did more. While daily meals were quite okay, I missed Friday's takeaways. I became more attached to the TV, but many programs just didn't agree. Listening to my music was best for me. Back to the 60s it had to be. A nostalgic trip down memory lane helped lessen the growing pain. Scared of heights, I'm certainly not into climbing, but exacerbation had me climbing the walls, and it wasn't often good timing. Of course, what needed adapting to was the Alzheimer's Club not operating. Not having the usual contact with members made it quite frustrating. However, all was not lost. Would Zoom online sharing do the trick? Who would the club coordinator pick? I had mixed feelings on how I would go. Taking it in turns could prove to be slow. Even though it was a success, I felt self-conscious about the whole thing. However, I knew of the benefits it would bring. I did have one connection problem, which left me out on a limb. Baffled how this could happen, I complained to Robin and Kim. A real positive was being able to do more writing. Rhyming poems and compiling quizzes seemed even more inviting. Research reading I enjoy a lot. I regularly tune in to TV's quiz slots. I was appalled by some people's actions being in breach of the rules. They were not taking the lockdown seriously enough or didn't have the coping tools. Our much admired Prime Minister was my inspiration. Her positiveness and reassurances were fitting of her station. The lockdown was for me an experience like no other. My mind went back in time. You wouldn't want to be here, my dear mother. I have a lot to be thankful for. In God I put my trust, believing He was watching over me. To keep the faith I must. Weathering the storm, I took it in my stride. In how the crisis was handled, I took great pride. Thank you.
Really, really useful reminder about what it was like, and also for sharing your personal story there. I think a lot of us saw some of our own reactions in your poem and in your experiences. So thank you very much. We really appreciate it. And now if everyone can join me in a virtual thank you to Ted. Thank you very much. Okay, Ted, now I'll just ask you to turn your camera and your microphone off now. All right, so now I'm very pleased to introduce our second speaker today, Lee-Fay Low, who many of you will know from her being a keynote speaker at our 2016 and 2018 conferences. So Lee-Fay is Associate Professor of Ageing at Health at the University of Sydney. She's a registered psychologist and has a PhD in psychiatric epidemiology. She is an author of over 100 peer-reviewed articles and 3 books on dementia, and she has a particular focus on improving the quality of life for older people and people with dementia. So welcome, Lee-Fay. We're really pleased to hear what you have to say this afternoon. Kia ora.
Kia ora.
Okay, I'll let you go.
I am sharing screen. Okay. So today I'm speaking about visitors to care homes, and I'm taking an international perspective. But first, I'm in Sydney, Australia, and I'd like to acknowledge the traditional owners of the land that I stand on, the Gadigal people, the Eora Nation, and their elders, past, present, and future, and also of the traditional owners where all of you attending this webinar are standing as well. I'd also like to acknowledge that this work is part of an international collaboration called LTC COVID, long-term care COVID, where people from all around the world have been writing about their experiences and their country's experiences of COVID and long-term care. And the work that I'm presenting today is unpublished, but it's a work that we're working on together around visitors and guidelines of visitors in care homes. So in March, we started to see care homes, nursing homes being locked down in almost all countries. Here's a paper from the US where the lockdowns, I guess, the care home lockdowns started open, and we knew that there were outbreaks of COVID within nursing homes. They were spreading fast, and people were dying. So that's why lockdowns happened. We know that once COVID-19 enters a care home, it's really challenging to prevent spread, and we know that care home case fatality rates are actually quite high, up to 40%, 35% of residents who get COVID pass away because of COVID. And so in almost all countries, there were restrictions, like in Australia, or complete visitor bans. So visitors, often a diagnosis, non-paid staff, basically were not allowed into nursing homes. Here's some mortality data from LTC COVID website showing, it's quite old now actually, it's from the middle of the year, but showing the bars are the number of deaths for the whole country linked to COVID, and the dots are the proportion, the percentage of resident deaths of all the country deaths. And you can see that the high dots, for example, Canada, 80% of all COVID deaths in Canada were residents in aged care. And the red dot there is updated data from Australia where over 70% of all COVID deaths in Australia have been in nursing home residents. So, there's really a lot of pressure, policy pressure, pressure from on nursing homes, basically, to try and stop COVID from getting to nursing homes. And so facility lockdowns to visitors was what we were doing. I guess what was concerning is that these policies were written really quickly in March as a response to these outbreaks, and in those in many of those policies, resident rights were secondary priorities. So they were not mentioned, or they were brushed over in many visitor policies and guidelines. So, for example, in the UK guidance, it says all decisions to be taken in light of the Department of Public Health and Care Providers' general legal obligations, such as under the Equality Act and Human Rights Act. So it says you should be mindful of human rights, but then in that same document it says, but we need to put visitor bans in place, unless there's exceptional circumstances in places with high local COVID alert levels. And Nathan Stall in Canada, in I guess their kind of ethical document, basically saying if aged care is resident-centered and caregiver partners, then residents are the people who should have sole authority and autonomy to decide who's essential in supporting their care. And it is a violation of residents' rights and families' rights to, ban visitors completely. And I think that, there is the balance, right? But I don't think we got the balance right. And I'll show you some data, I guess, around that risk balance. In some visitor policies, and I've listed them there was distinction between family carer visits, so families who came and did essential caregiving, feeding, really doing social support with the person, getting them ready for the day. And those are the families that you've met. They come every day, or they come very regularly. They come every weekend and spend time with the resident, often other residents as well. So really they wanted to distinguish between those family visits and the more casual social visits. And in some of those policies, family carers, with different levels of distinction, were given access, so they could actually go in where they couldn't in some places, or greater access, so they could go more often, or could stay for longer, or they were given less supervision during the visits. And the way they were implemented was that some family carers, that those family carers had to do, more training and use more PPE. So the family carers were kind of treated as unpaid essential staff. We all know that a lot of those family carers do a lot of the daily care work. And we have been concerned about, without those family carers there, either the staff are working a lot harder, or residents are getting, less quality care because the families in many places aren't there, or can't do the same hands-on care that they used to do. I looked at your New Zealand guidance, and it also had a rationale around protection. So it said that the following groups should be restricted from visiting residents: families, friends, non-essential visitors and volunteers, non-essential healthcare workers. You didn't have a complete visitor ban, and so I saw that some facilities opened to visitors early, so before you went to level 1 alert. And in this guidance documents, there's no mention of resident or family rights, or even resident wellbeing, or looking after resident wellbeing. And this isn't unusual. So what happened then with these lockdowns and with residents, not being able to see their families? We were already in Australia had a Royal Commission into aged care, and so they added a special session of hearings around COVID. And here are some of the findings. Our Royal Commission found that visitor restrictions has seen a large increase in depression, anxiety, and confusion in residents, as well as increased risk of suicide. It found that visitors are really critical to the physical, mental, and emotional health and well-being of residents, and that the benefits could not be wholly replaced by technology. And it recommended that our government should immediately fund providers for adequate staff to allow continued visitors to people living in residential aged care by families and friends, because safe visiting procedures takes staff and takes equipment. And if you don't have staff, it's actually easier, cheaper to keep your lockdown than to have, a booking system, a screening system, a cleaning system, and then staff to, supervise, bring the resident to the visiting area or guide the visitor to the visiting area and make sure that that visit's done safely. This is a Dutch study with residents, visitors, and healthcare professionals. So a really large study, and it looked at the impact on residents during the lockdowns. And it found, similar to our Royal Commission, high levels of loneliness, depression, and increase in exacerbation of mood and behavioral symptoms. And here are the data. If you look at the far right columns, that's the brown columns, that's like the increase. So you'll see that, there was a big increase, 68% in depression, an increases in anxiety, an increase in sadness, restlessness, increase in irritability, and really increases in almost all the symptoms except for elation and euphoria, which all makes sense. What's been interesting is that in most countries, the facility lockdowns were legislated under, emergency acts, and in most countries, you just had to close your doors to visitors. But the responsibility for deciding to reopen facilities has been left to individual homes. And homes not just have to decide that, there's some criteria for deciding. So I show you the CDC guidelines, which many of the states, United States legislations also say, which say when the home decides to open, it needs to show that before allowing visitors, they have enough PPE, that they have, they can get testing, they have enough staff, that they consider COVID levels in the communities, though there's no figures about what is appropriate, and that there have to be hospital beds in the areas. When I look at that list, I think, well, the home can control some of those things, but shouldn't it be a shared responsibility between the government and the homes in supporting them to reopen? And that's certainly been one of the outcomes from our Aged Care Royal Commission as well, that the federal and state governments, I think, haven't been working as closely and supportively with homes here as they could have in preparing them to be ready for COVID, and in supporting them, I think, to support the well-being of residents during COVID. So here and in many other countries, the care homes locked down beyond the restrictions. So in Australia, we didn't have complete bans. We had visitor restrictions, but all the nursing homes locked down. Actually, there's a few chains that didn't, but almost all the nursing homes locked down. And there were concerns that with no visitors and with the regulator, our aged care regulator, not making unannounced inspections, that no one was keeping an eye on what was happening inside the nursing homes. And after kind of the first wave, our Prime Minister, Scott Morrison, started to warn aged care facilities that they better start allowing visitors. But facilities were really reluctant to open. And they really started to kind of push back against the Prime Minister, I think, and defend their lockdowns. Oops. And we did open in May. So in Australia, our facility lockdowns in the first wave went for about 2 months, and in many facilities we had Mother's Day visits. What was interesting here in Australia is because there was really lack of clarity, guidance on what best practice was. Many of the peak bodies, Carers Australia, Council for the Aged, Dementia Australia, National Seniors, the peak bodies for our residential aged care sector, many of the leading aged care providers all got together and they wrote an industry code for visiting. So like what safe, good visiting would look like. So they jumped ahead of the government. They set policy for government because there wasn't clarity about what best practice was. And this code, it has been updated since its first draft came out. When I say this lack of clarity, these are data from some selected regions showing, I guess, when they closed to visitors or restricted visitors, when they reopened, the type of visit that was allowed. In most places, indoor visits, but in a few places, they only were allowed outside visitors. And then the COVID situation in that country at the date of reopening. I'm going to draw your eye to the third column from the right, which is called COVID-19 incidents in past week per 100,000 people. And it's showing that there's basically a huge range in how much COVID there was in the country, in that region, in the community, when facilities reopened. And you can see down the bottom, the data for New Zealand, your second wave lockdowns of nursing homes. We also had second wave lockdowns in Brisbane and in South Australia, and that by the time they reopened, there was almost no COVID in the community than when they reopened. But in other places, there was some COVID or like 100 times more COVID in the community, and they reopened. And I'm not saying it's right or wrong. I'm just saying that there's really no guidance about like how to judge when it's safe to open based on community transmission. And that in context, it's not just how much COVID there is in the community, but what the visitors are doing, like how likely it is the visitors will get infected. So I put the Oxford Government Response Score, which is showing like the measures the governments are taking in response to COVID as well. And it shows, I guess, the different levels of response. So I'll go back here and draw your line to the Netherlands line. You'll see that they had quite low levels of COVID by the time they reopened. But before they reopened, they ran a pilot, which is now published, of 26 care homes in different regions. They didn't actually talk to families about the impacts. They just talked to facilities, basically. And what they found is that all homes said there was added value of real and personal, so in-person contact between residents and loved ones above what you could achieve through technology, and that there was a huge positive impact on well-being. There was variation in how the national visiting guideline was applied. So there was national guidelines, but in some homes, all staff and visitors had to wear masks, but in some homes it was needed. All homes did screening of symptoms, but in 2 homes they did it, the day before by phone. Most temperature checked at the visit, and there was really variability in whether the visits were supervised, so whether there was a staff member there or not. And they also reported that in some facilities, physical contact, so a hug was allowed. And if they were unsupervised, we don't even know if people were hugging and kissing. So it's really interesting, I think, that even when you have guidelines, they are implemented, they're interpreted, implemented differently by different facilities. And certainly that's what's happening here in Australia, and I'm sure that's what's happened in New Zealand as well. They also reported a significant increase in workload for staff, and I already talked about how you need staff, like much more staff, to do safe visiting. They've had no COVID-19 outbreaks in aged care facilities during the pilot. And speaking to our Dutch colleagues, after this pilot, they opened 2 visitors, and in the 2 months after that, they didn't. But I know things are getting bad in Netherlands again now, and they're in partial lockdown. I don't know what's happened in terms of visitors bringing in COVID. I just want to mention, I guess, that we don't really know how resident,
Sorry,
we don't-
Lee-Fay, can you hear me?
Yes.
Sorry, just to let you know that we've gone a bit over time.
Oh,
so,
sorry.
I don't want, this is absolutely fascinating, and I know we want to focus on this, but I'm conscious of our other speakers.
Oh, yes, I will wrap then.
Yeah.
I will say basically that from our report, we're recommending that complete visitor bans should only be introduced as a last resort, so that you should be basically putting in all the other policies and practice where we know there's better evidence, because actually there's very little evidence that visitors are bringing in COVID to care homes because we don't have the data, and we should be doing other things instead. We should be using safe on-site visiting practices. We should fund those safe visits, and we should have regulators making sure that care homes not just doing safe visiting, but that they meet the resident rights to have visitors as well. I'm sorry for going over.
Well, to be honest, Lee-Fay, I was so engrossed in what you were saying that I wasn't checking the time, and so I didn't even realise that you had gone over. And I'm sure that many of our listeners today were in the same situation, because you've really touched on such an important tension that sits there between those public health imperatives and human rights imperatives, but also the reality that visits are much more than social contact, and the impact of not having that engagement is huge and poorly understood. And of course, the reality that we don't actually know whether, the infections to date, certainly in New Zealand, have come from staff and not from visitors. So, our view is that there must be a better way to do this. But I am sure that this is going to come up again in the questions. So I'd ask the rest of you to join me in a virtual thank you to Lee-Fay, and thank you very much, and we will come back to you later. All right, so now I'm delighted to introduce our third speaker today, Heather Lackner. So Heather is the manager for Alzheimer's NZ, Tasman. She has worked with older people and people with dementia for 30 years in a range of roles in the community and residential care, and for the last 15 years at Alzheimer's NZ, Tasman. And today she is going to talk to us about the experience of her client group and how Alzheimer's NZ, Tasman responded to that. So Heather, can I get you to turn your camera and your microphone on?
Can you see me?
Yes, can see you and hear you. So over to you, Heather.
Great. Oh, thank you. Thank you for this opportunity to share with you our experience of COVID. So as you said, Catherine, I'm going to talk about how it affected our service, our clients, our staff, and how we here responded to it. So it actually started in Nelson here. After the Christchurch earthquakes, our building was closed and we couldn't access any of our files or our resources. So back then we started a process of equipping our service to work remotely. We had laptops and phones in place. So actually, I think that when we went into lockdown this time, it possibly made it a little less stressful. We were already able to start working from home, which was good, because we could just get on and look at how our service was going to continue. So our initial plan was to contact all of our clients, but with almost 300 people living with dementia on our books, it wasn't going to be easy, because we're actually only a very small team of 2. But we actually did have another lady starting, but we had to put that off until the end of lockdown. So together, we got together, my partner and I got together, and we identified our most vulnerable clients. These were people that lived alone with no family locally. They had no outside supports, and they were the people that we contacted first. And from there, then we went on to contact our other clients and families. When we contacted them, we looked at and spoke to them about what services they had coming in. We talked about what they needed, establishing an ongoing plan. We were able to make sure that they had supports in place, but also that they knew who to contact if they needed anything. Sometimes it wasn't even anything to do with that. Sometimes they just needed someone to talk to and to be listened to. We were also connected on Zoom with a number of local service providers like Nurse Maud, Access, Presbyterian Support, Age Concern. And between us, we were able to identify the clients that we had in common and then work out who was going to be the lead person. This stopped our clients getting numerous phone calls from a whole lot of different people all at once, which would have been just really overwhelming. So from there, we set up, there was a weekly Zoom session set up with the service providers, and also the needs assessment team joined and the local DHB, which it was a really good opportunity to ensure that we all knew what was happening locally, but also it gave us a chance to discuss any concerns that we had and share any information for, that we could then give to our clients and our families when we contacted them. So the next thing that we did from there was that we had to look at how we could continue to provide a service which kept our clients connected and supported and feeling less isolated. So we'd already set up a messenger chat group, and this had been set up for our people living with dementia. They were meeting regularly face to face, and so we set this group up so that they could connect online. But we were really quite keen to try using the Zoom platform, which we'd actually been using as staff for meetings. But we'd actually never initiated one. So we thought, well, how hard can that be? So we purchased Zoom, and then the fun began. We not only had to get to grips with using the technology as presenters, but we also had to become really quickly comfortable with it and confident in guiding and encouraging our clients to use it. And that wasn't easy, and it did take considerable time, and it was very frustrating for both our clients and for us. But, you know, we got there. We just kept going. We started small. We started actually with people living with dementia. We had small groups that what we did was we sent out information about Zoom, then we connected via the telephone, and we talked them through connecting with Zoom on their computers. It took a few times working like this, but once they felt confident, we were away. And then what we were able to do is we were able to just continuously add more people to the group. I think what really helped them was that we made sure that we were able to connect with them on the phone, so that they knew that if they had any trouble with Zoom connecting, that they could just ring, and again, we would talk them through it. Not everybody was able to access the online group. So what that group did themselves was together they worked out and they set up a tree, a communication tree. And they worked out who they were going to call. And so after they'd had the Zoom session, the people that were going to call people made the phone calls. And the feedback was that those people that got the calls, that's what they really looked forward to. It was on a Monday, and they just really looked forward to their calls from their peers. Our next mission was setting up our carer support groups. So again, we did it exactly as we'd done with our early groups. We called people, we phoned them, and then we talked them through it. We had people that had never used technology like that before who were very resistive, but slowly we ended up being able to run 3 online support groups a week. And we used to run our groups monthly, but because everyone was home, it was their choice. They actually wanted to meet weekly. We had people that had never ever joined a support group before that were joining our groups. And some of them still continue to join our support groups now, and we are still continuing to run an online support group. What we also found too was that once we'd set our groups up and people felt really comfortable with using the online platform, that they started connecting with their families via Zoom, which, you know, the feedback from them was they'd never thought about that before. So that was a real positive. We had a volunteer who offered to write a weekly information sheet for us, which had tips around activities and different ideas that people could engage in. And we would email these out to our clients regularly. We also used them when we called our clients too, being able to give them ideas. I think for our clients and their families, the experience of COVID was possibly as varied as the experience of dementia. It was very different for everybody. Some really enjoyed the time out, others not so much. Some enjoyed it to begin with, but some were really over it by the end. And these are some of the things that our families and people living with dementia shared with us, that some of them really enjoyed the slower pace of life. They felt that there was no pressure to be anywhere. There were no appointments that they had to keep. And they really enjoyed not having people come in and out of their home. A number of people shared with us the anxiety that they experienced when their person was living in a care facility, the anxiety of not being able to go and visit them, but also they had no idea when they might see them again next. And they were also, you know, there were concerns that when they did get to go and visit them, would the person recognise them? And a number of our families spoke about that when they did get to go and visit their person, they noticed a decline in the person's ability, which they found really upsetting. Support from home care providers became an issue. Some felt a lot of apprehension and fear of letting the providers into their home, so they just cancelled all the services, while others had service providers cancel the services. So when they were used to getting a service, that was no longer available to them. Other things that we talked about with our clients were the respite options. These became very difficult to access if needed, and especially day programs. Day programs in our area ceased completely, which saw an increase in isolation for the person living with dementia and a rise in carer stress. Care partners talked about how their person living with dementia found it really difficult to understand the situation sometimes, and sometimes they became cross, accusing their family that they were trying to keep them locked away or keep them away from others, which caused stress and tension with both. Some of our people with dementia talked about how others made choices for them, and one really interesting one was one of our people living with dementia talked about when they made their grocery list for their family. The family decided what they would and wouldn't buy on the grocery list, and one of the things that they thought that the person didn't need, because they were health fanatics, was the chocolate biscuits, so they wouldn't buy them for them, which, you know, our person became quite upset about that. Another thing were the supermarket restrictions. A few of our clients who chose to continue to go to the supermarket said that they felt very uncomfortable when they had to go. They felt that people looked at them as if to say they shouldn't be there. And one of our younger care partners was refused entry into the supermarket because they had their person living with dementia with them. And of course, the policy was only one person per family, but they couldn't leave their person in the car or at home on their own. So that was a difficult situation for them. I think as staff, you know, we learned a lot and experienced a lot. It totally took us out of our comfort zones, having to look at how we provided our service. We learned a number of new skills. We had to embrace technology and overcome the daily frustrations of it not working how we thought it should. And there was no one there that we could ring or get to come and fix it. We just had to work through it. It highlighted how stretched our service was, and that's something that we're going to have to address moving forward. But it also showed us that we are still able to provide a service for our community, even if it was in a completely different way, and that we have some really amazing and resilient older people in our community. And that's it.
And I think, you know, one of the things that really characterises that experience is, you know, the extent to which we find in those circumstances that really anything, or indeed many things, are possible that we didn't know that we were going to be able to do, and we find ways to make changes and to do things much quicker than we would in normal life. So, you know, one of our challenges for the future, I think, is, you know, how do we take that experience and that benefit into the future? And of course, that's the topic of the third webinar. But thank you very much for sharing that that experience with us. It was a really comprehensive but really useful overview of your experience and the experience of your clients. So thank you very much. And please,
You're welcome.
To say thank you to Heather, and we'll see you later at the questions. All right, so I'm delighted now to introduce our final speaker today, Diane Turner, who is probably also known to many of you in her role as Director of Office for Seniors. She's been in that role for about 4 years now and has been a very strong advocate on behalf of older people through that time. But she brings to that role a wealth of experience in a variety of sectors, including working for iwi, working for the whānau or a commissioning organisation, working for local and central government. So I'm delighted to introduce Diane to you. Diane is sitting beside me, you'll all be surprised to know, and so I'm just going to pan the camera around to her, and I just bear with me while I turn it, make sure I turn it the right way. Oh no, I'm going the wrong way. That's the second time I've done that. Let's try and get it round the right way. Here she is. Welcome, Diane.
Thank you very much, Catherine. Technology failed me yesterday, so I've ended up with Catherine, and I feel a lot safer with that, because I was a bit concerned, as we all are, when we have to test new technology. So I'm going to take a slightly different tack, because, of course, working within central government, I have a bit of a national perspective on what happened, and so I'm going to cover in my presentation, which hopefully will appear on the screen shortly, I guess just a few slides. It seemed very hard to summarise everything that's happened for most of this year in a few slides, so I'm not going to be covering all the issues that have impacted on people, and some of the information that I've got in my slides has actually been covered by previous speakers, so we'll skip over some of that. So just I just click the buttons.
I think click the arrow.
Okay. All right. Just getting the technology sorted here.
Yeah.
So just talking about the office initially, we're a small office based, and we're based in MSD, and we're a total of seven staff who have a national role supporting the Minister for Seniors. During the COVID lockdown, we really became the COVID response office, and focused our entire efforts on supporting the response to COVID, and we did this in a number of ways. I was really fortunate in being able to secure a seat in the National Response Centre under what became called the Caring for Communities team, and in this way it enabled me to provide advice directly into government, as well as sharing intelligence and the information that we were getting in the office on older people's issues, and influencing what was happening on the ground. We have a strong relationship with stakeholders across the country, and we called on them to share key information with us, so that we could then advocate on their behalves and I feel that over the time we had a really good system operating. We also have a really strong communication with older people through a bi-monthly newsletter called the Super Seniors Newsletter. It now reaches well over 300,000 people, and we took it from a bi-monthly to an almost weekly publication, ensuring that people had key information that was relevant to them. It retained a high readership with an opening rate of over 60% through all our publications. Our minister was keen at one stage on us being able to do a household drop, which is important because a lot of people actually don't have access to email, but regrettably postage alone put it out of anybody's reach. The other thing that we developed, one of the issues that we really face is that older people's issues don't really are not central to considerations of government at many different levels. So we decided fairly early on that we needed to be able to chart the progress of the impacts of COVID on older people. So we have developed a small suite of indicators which we're reporting on quarterly, and I've given you the link there to our website, and you'll see the initial base report and then the late August publication, and we're going to be putting together another report in November, and that is designed to see the impacts over time. Now I'm going to cover off a few issues, and the first one is the right to work. But I was kind of really astounded when the lockdown first hit us, and older people, people over 70 were instructed to stop working immediately. Older people are a significant part of the workforce, and in the table presented in the slide, I actually give you the data on the number of people who are in paid employment. But of course, you all know that there are also a lot of people in unpaid employment, not only as carers for partners, but also other family members, children, grandchildren. And they were immediately kind of withdrawn from the voluntary workforce. And so there was quite a significant, there are a couple of things about this. We're actually withdrawing a whole lot of people from the workforce, but we're actually pulling out a lot of the supports that we have in society within families, NGOs and community organisations. And those gaps are not easily filled or very quickly filled. A couple of observations about the right to work. I was really impressed that the employment subsidy was available to anybody. Traditionally, government talks about working age employees, and that means that once you hit 65 and qualify for New Zealand Super, you're no longer entitled to the likes of generally unemployment benefits. But the subsidy was open to everybody, and I think that was a really great step forward. In a post-COVID world, if we can call it that, we are seeing that the underutilisation rates are increasing amongst older people in terms of employment, and IRD data indicates that older people have been earning less since COVID. I also note that much of the job seeker support is focused on youth and manual male-dominated occupations, when in reality we know that females have been severely impacted in terms of their service roles. Now so used to just pressing the next button. So my next slide is on accessing essential goods and services. I think the digital divide became increasingly apparent during the COVID lockdown. banks closed their doors, and now many banks have closed their doors forever, and others are operating on reduced hours. Online shopping went online, and simply supermarkets, as we know, just were not able to cope with demand. And, I mean, that is no particular fault of theirs. But yeah, it took a while for systems to get up and running to support our ability to get goods and services. And associated with the online shopping, if you couldn't access the online shopping, payment was also often an issue. So that was a kind of a double whammy for a lot of people. To top that all off, people are still used to going in and paying bills personally, using their post shop, which was also closed, to pay bills. Sort of with cheques disappearing as well. That caused a lot of stress amongst some people, and it was great to see, the telcos and the utilities responding by giving people time to pay their bills, so services weren't immediately withdrawn. Moving forward, there needs to be a huge focus on increasing digital inclusion through not only addressing the training and development needs of people who are willing and able, but also the issues of affordability, both for devices and connections. And one of the stories I heard about, while people might have had devices and were connected, their devices were often so old that they couldn't download the COVID app, or they couldn't join Zoom because they had no cameras. And I remember talking to a person that provides an online service to older people, and she redirected much of her workforce into helping older people sort out all their technology so that they were able to participate in this new world. We also need to ensure that there are sustainable and safe options for payment and accessing services, because not everyone is going to be able to be digitally included in this new world. All right, the next slide is on accessing care and support, and there's been quite a bit of discussion by the other presenters on this, but I will make a few comments on this, and sort of the often unilateral withdrawal of home support services, which affected a substantially greater portion of people than those living in residential care than we really know about. We've talked about the lack of respite care, lack of national consistency around decision making about what was happening. That was something that was regularly relayed to us, and for organisations delivering national services, it became increasingly difficult. We've talked, Lee-Fay in particular talked about aged care facilities, but retirement villages, people have bought into a lifestyle, suddenly found that they weren't able to form their own bubbles, and they weren't free to do what they wanted to do as if they were owning their own homes, which is kind of the story that they're told before they move into these villages. And I certainly think these are things that need to be talked about as we move forward, because I think that unilaterally locking down and removing people's rights to make decisions and treating people as if they aren't capable of making informed and good solid decisions is simply not acceptable. Accessing medical care or GP by phone and in car parks and for way too long, in my opinion, impacted on people. And, we saw a great withdrawal of, in terms of numbers of people accessing medical support. In fact, the part of the campaign was encouraging people to go back to their doctors. The ongoing issues over personal protective equipment, was just really troubling. As we move forward, we need to have planning in place that ensures people can access the services and supports that they need, and that they have some control over what is actually happening. This presentation can't go without mentioning issues related to discrimination and ageism. And I could not believe what I was hearing when the pandemic first arrived, and I was searching for information about older people and older people's issues under the tab called vulnerable. Consistently hearing people being talked as elderly or the elderly, and that continues through today. Being issued instructions. Somebody's already mentioned that older people experience verbal abuse as they exercise their rights to be going out and about. And I've included this poster in my presentation. I was so incensed. I had spent a lot of time talking to COVID comms about the rights of older people and how to talk to them, and I could not believe it that they decided that this was a great idea to encourage younger people to wear face masks to protect older people, when there was plenty of information. This was an late August poster, so by that time there was plenty of information around to be actually engaging and educating younger people about the risks of COVID for themselves, and them needing to take responsibility. I think at the end of the day, all people, irrespective of their ages, need to be provided with the information that they need and require to help them make informed decisions. In kind of being critical of this, I think, comms, the communications that happened over COVID was actually they were really simple messages, but it wouldn't have taken too much effort to make the messages more attuned to the needs and issues of older people. So elder abuse is one of the big issues that affects older people, and we now have a national service. I was really pleased when the government provided top-up funding to all the regional services providers at the start of the lockdown. I was immensely pleased when, during the budget this year, a further 25 million over 4 years was announced to support the Elder Abuse Response Service, which is a huge increase in funding. Currently it's just under $3 million a year, so it's a doubling of the budget, and it is a beginning of the recognition of the issues of elder abuse. It's been difficult to get statistics about what is happening, but generally it would appear during the lockdown that there was reduced reporting, which surprises none of us, because actually the people that are being abused generally don't report it themselves. It's friends, neighbours, service providers. So that was not unexpected. However, now that we're well past lockdown, we are hearing increasing incidents of elder abuse, and this is something that's somewhat concerning. And certainly, I would like to see much better services and reporting in place. And this is my final slide. So, a lot of the stuff around older people is around social connection, because social connection and participation actually impacts on people's well-being. And I think that's been well said already in the presentation. Just a couple of things that I wanted to talk about was the Ministry of Social Development, the regional commissioners connected with community organisations to do outbound calling, and they firstly they worked kind of backwards from people 90 plus through to 70 plus, contacting people living alone and with no recorded email address. By the end of the calling period, which was over about a month, they'd made over 100,000 calls to older New Zealanders. I think a couple of the pleasing things were that only 3.3% of those calls required a referral to another service. And there were only 46 calls which required an emergency response. So, it was, I'm really grateful that of all the effort that went into making those calls. I will say, one of the challenges that we have with MSD is people join up for New Zealand Super, but unless they've need to contact MSD, there's no ongoing or regular contact. So people don't actually have up-to-date telephone numbers, addresses, email addresses, which would enable communication to happen more freely. So I think that's a thing to look to in the future. There are lots of local initiatives going on, and I think we've heard some of that already. And I think we need to look to a response, including better funding for community organisations and groups. There is some going out to older people, but I think there needs to be a far greater recognition of the 800,000 plus older people that live in New Zealand. Thank you.
Thank you. I think that we can just do this. Excellent. And I'm going the right way this time. So thank you very much, Diane, for that really interesting presentation and an overview of, not just the experience, but also the way in which those matters were thought about, in particular around the communication and employment and other things. I think we've got a real challenge in thinking about, well, how do we deal with this on a longer term? So please join me in thanking Diane. And now, and apologies for taking a bit of extra time with a couple of speakers, but I was fascinated, and so I did lose track of time slightly. Now, in breaking news, I just thought I would let you know that the end-of-life referendum has passed and the cannabis referendum has not passed. I think that's probably no surprise to anybody. All right, now I'm very pleased to introduce Peri to you. Kathy will be known to many of you as a nurse researcher, as a educator, and also as a trainer for CST, and she's also now part of the Alzheimer's New Zealand family, and she is moderating the questions today. So she's been keeping an eye on all of your questions. She has the unenviable task of trying to get through as many questions as possible in the next 10 minutes, Kathy. So can you turn your microphone on and your camera on and let us know who the first question is directed to?
Firstly, thank you everybody for sharing your COVID experiences. A comments to Ted first. I wanted to share some of those comments that were raised by the attendees. They gave feedback as was creative, captured a lot of feeling during that COVID for me. Amazing, a good reflection, and a beautiful, beautiful poems. So I just wanted to thank you, Ted, for sharing that with us. Now we have, I think for time, I think we'll go to the panel question first. So we'll start with Lee-Fay, then Heather, Diane, and if Ted would like to come in at the end, that would be great. So the question is, what is the single most important thing from your perspective that will make the most positive difference for people living with dementia if or when COVID restrictions are required again? Let's Lee-Fay.
You won't be surprised to hear that I don't think that we should restrict visitors in nursing homes. I mean, we can do safe visiting practices. We know quite a lot about how to do that, but no restricting visitors. And that will make a huge difference for people with dementia living in residential care. That was very short.
Heather?
I think it's about ensuring that social connectiveness, that we can keep that going for our people, and also the respite options, looking at different kind of respite options so that they can still be available for our people living with dementia and their families. That's me.
Diane,
For me, I think decision needs to be decisions. People need to be able to make their own informed decisions rather than being told what they can and can't do. And that, you know, that applies to everything from what's happening in the aged residential care through to the home services to participating in normal activities. We need to be able to keep life as normal as possible.
For Heather, I think we have time to cover them both. The first question is, Heather, what lessons from the COVID experience have you continued to use in your delivery of your services now?
Still running a carer support group via Zoom, so we have a number of carers that actually can't attend a support group, so by holding a Zoom session for them, they're still able to be connected with other care partners and and get some support. So that's, for us at the moment, that's one thing that we are continuing.
What do you think we could do better for care partners during the COVID? Because the research has certainly showed that it had some quite profound effects for care partners. So what can we do during lockdown more for them?
Is that for me?
No, well, you can come on. No, it was for Heather. That was her second question. Heather, but Lee-Fay, if you've got an opinion as well, we'd be very interested to hear it.
So for carers of people living in the community, social services shutting down, like, we need to think about how, like, where that money was funneled, and, you know, whether you could be offering one-on-one respite. You need to be thinking about whether you could be doing Zoom respite or some other way of, I think, supporting carers to have a break. And then, as Heather's been doing, running social support groups by phone or by Zoom. I mean, Zoom doesn't work for everyone, but certainly, you know, giving a buddy system and having people phone and talk to each other will make a huge difference. So emotional support and practical support, I think we need to make sure that we know how to keep it going.
Would you like to come in now and share your views?
I think someone made a comment on it, is that often the care that was going into the homes was actually, there were a lot of people going in and out. You know, if we can reduce that so that the care can still be going in, but maybe that there is just one person providing that, not a lot of people doing that. I don't know whether that's possible, but those respite options are really important for our care partners, because without that, we end up, like we're seeing, once lockdown finished, there was a huge amount of stress and tension in families out there. So I think that respite options really need to be looked at for our care partners.
I have a question for you. You presented your data on the research on the impact of the COVID on residents and families. I was wondering, was there any research showing about the impact of restricted visiting on the staff?
Papers on the impact of COVID on staff, and we've certainly been talking to facilities as well about it. It was very, very difficult and stressful for staff. They were worried about getting COVID. They were worried about taking COVID into the facility and making the people they love, the residents they love in the facility, sick. They were worried about taking COVID home, and the same, I think, concerns that healthcare workers had, aged care workers had, but aged care workers tend to have less education, less pay, less support and training in infection control during COVID. We know that many staff didn't know how to use PPE correctly. They didn't understand the correct infection control conditions. Trying to maintain social distancing in the facility was very difficult. Not having families there was very difficult. Facilitating conversations with families who are demanding information was very challenging and difficult. Getting visitors, safe visiting protocols is very difficult. It's been very, very challenging for staff. And in Australia, and I would guess in New Zealand, that we tried to not have staff work in multiple facilities, and for those staff who needed to work in different places to make money, not just like care staff, but the hairdresser and the podiatrist and the massage therapist and stuff, that was really challenging as well.
It's just popped up. What would your recommendations regarding one family member staying with a resident living alone in a retirement village, for instance, or even in aged care? Because I've read some literature around families actually came in and lived in the bubble because of staffing shortages and for other reasons. So what's your thoughts around that?
There's certainly anecdotal stories of that happening, like in the newspaper. So we know a family member who moved into the nursing home and lived in lockdown with their loved person. We also know many stories of people who brought their person home to live with them at home during the lockdown. Those things, I guess, are safer in terms of risk of COVID, and probably better for the residents' well-being if the family member has the capacity to do that, and I guess has the resilience to do that. And I think the one person I talked to who did that, it was a really meaningful thing for her to do. She really connected with her parent in that time. It's just that it can't be the solution, because a lot of families won't have the ability to be able to do that.
Between groups of providers that were more owner operators, the smaller not-for-profit than the larger corporate facility, or would you be prepared to make a comment on that?
So,
and if you do, make it a very quick one, Lee-Fay.
There's data that shows that nursing homes that have better staff ratios and better quality ratings were less likely to have COVID infections. In some places, not everywhere, there's a correlation between for-profit and not-for-profit status and COVID, and staff ratios. So, there's some suggestion. So there was Canadian data that showed that the for-profits were more likely to have COVID infections, but when you looked at why, it was because they had really old buildings, which made it harder to isolate. And they couldn't just say it was because of the profit status. So possibly is the answer.
Okay. I think it's handing over to you, Catherine, for the last.
Yes, I think we'd better, because we're almost about to go over time. So I've really got time to say thank you to our participants today and for your questions. Really appreciate them. A huge thank you to our 4 speakers today: Ted Normanton, Lee-Fay Lowe, Heather Lackner and Diane Turner. And please join me in one final thank you to everybody. Look, I think if this session has done anything, it's really reinforced that the existing stigma and myths for older people and for people with disability were heightened through COVID and underpinned quite a lot of the issues that we've talked about today. And that leads us very nicely onto the topic of our third webinar, which will be in a month's time. So that one's going to focus on looking forward. What are the opportunities available to us, and how can we start to do more and better? So I do hope that you can all join us then. If you're registered for this webinar, you'll be automatically registered for the next one as well. So thank you very much. Ka kite anō.